Rotator cuff disease. Published by WordPress.com. Subacromial impingement. Introduction. First stage of RC disease, commonly caused by outlet, external, impingement. Anatomy. Acromion. Formed by three ossification centers. Meta-acromion base. Meso-acromion mid. Pre-acromion tip. Failure of fusion os acromial. Bigliani classification. Type 1, flat. Type 2, curved. Type 3, hooked. Pathophysiology. Risk factors. Hook-shaped acromion. Os acromial. AC joint arthritis. Thickened coracoacromial ligament. Subacromial bursitis. Clinical presentation. Pain. Insidious onset, worsened by overhead activity. Night pain, radiates to the back. Tenderness. Over subacromial space and AC joint. Positive tests. Impingement tests. Near sign, Hawkins sign. Supraspinatus tests. Job's, Emptykin, test. Drop arm test. Imaging. 1. X-rays. AP views, neutral, IR, Supraspinatus outlet view, to assess acromion morphology. Findings. Proximal migration of humeral head. Type 3 acromion. AC joint arthritis. Calcification of coracoacromial ligament. Cystic changes in GT. 2. MRI. High signal on T2 in supraspinatus tendon tendinopathy. Fluid in subacromial bursa. Management. Conservative treatment, first line. NSAIDs. Avoid overhead activities. Rehabilitation. Strengthening RC and parascapular muscles, ROM exercises. Subacromial steroid injections. Operative treatment, if conservative fails for 4 to 6 months. 1. Acromioplasty, subacromial decompression. Approaches. Open. Using bone rasp, deltoid repaired to bone. Arthroscopic. Using shaver, burr. For os acromial, 2-stage surgery to avoid deltoid dysfunction. Complications. Deltoid dysfunction, due to failed repair or excessive excision. Anterosuperior escape, following coracoacromial ligament release in irreparable RC tears. Disease. Published by WordPress.com. Subcoracoid impingement of the shoulder. Introduction. Subcoracoid impingement refers to the compression of the subscapularis tendon between the coracoid process and the lesser tuberosity of the humerus. Pathophysiology. Position of maximal impingement. Occurs during adduction, flexion, and internal rotation of the shoulder. Risk factors. Long or accessory lateral coracoid process. Posterior capsular tightening, often seen after prior surgeries. Associated conditions. Subscapularis tendon tear. Clinical presentation. Pain, localized to the anterior shoulder, exacerbated by rotation. Tenderness, over the anterior coracoid. Response to steroid injection. Pain relief confirms diagnosis. Imaging. 1. X-ray. Assess coracohumeral distance. 2. CT scan. With arms crossed on the chest. Coracohumeral distance less than 7 mm suggests impingement. And 3. MRI. Evaluates the degree of rotator cuff pathology and coracohumeral distance in axial views. Treatment. A. Conservative management, first-line treatment. 1. NSAIDs. 2. Activity modification. 3. Rehabilitation with stretching exercises. And 4. Local steroid injections for pain relief. B. Operative management. Indications. Failure of conservative treatment. Subscapularis tear secondary to impingement. Surgical techniques. Coracoplasty. Resect the posterolateral coracoid to create a 7 mm space. Subscapularis repair. Repair of subscapularis tendon, if torn. Reattachment of conjoint tendon, if necessary. Open or arthroscopic approaches can be utilized.